Hello, my name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, and today's educational video is on the physician fee schedule proposals for 2025. So this video is being recorded on July 18th, 2024. So if you are watching this video a little bit later in the year or in another year, please note the date on this and that we are talking specifically about the proposals as we understand them on the date of July 18th, 2024. Few disclaimers before we get started. Please note that any information provided in today's talk is not to be regarded as legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. And also, if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any type of relevant financial interest, arrangement, affiliation, or relationship with such a company. A bit of background about CCHP. We were established in 2009 as a program underneath the Public Health Institute focused in on California telehealth policy. However, an opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through funding from HRSA, and we applied for that, and we've been serving in that capacity ever since. So we also work with a variety of other funders and partners on the state and federal level on not only telehealth, but connected health policy issues and projects. CCHP also acts as administrator of the National Consortium of Telehealth Resource Centers, and that is made up of the 14 telehealth resource centers, including CCHP, who are funded from the same funding stream from HRSA regarding the telehealth resource centers. So this was formed to really maximize our federal funding to provide, as many resources as we can to the public and also in the most efficient and effective way possible. And CCHP also acts as a convener for the California Telehealth Policy Coalition, which is an affiliation of over 150 different state and national groups who are interested specifically on state California telehealth policy. So we're going to get right into it and talk about what proposals were made for 2025 by CMS in their physician fee schedule. Now, a bit of background for those who may not be familiar with what exactly is the physician fee schedule. That's basically just a name that's given to a set of policy changes that CMS makes each year that impact the Medicare program. These changes are made because there may be new legislation that puts in a new policy and CMS needs to implement it, or they're updating information, things that just happen that require them to either make a change to policy or implement a new one or make updates to it. This process they go through is a regulatory process. So it's not legislation. So it's not Congress passing a bill or anything like that, but it may be triggered because of legislation, as I mentioned earlier, because a bill was passed and enacted and signed by the president. So now CMS needs to implement a new policy. But the process itself with the physician fee schedule is a regulatory process. Now, there is generally the proposals that they make. They do this every year. It generally comes out in July. And then there's a 60-day comment period for the public, and they're required by law to do that, to have this comment period where the public can provide their input and feedback to CMS. Once that comment period ends, CMS reads all the comments. They're supposed to read all the comments and respond to them, and they publish that in something called the final rule. And that usually comes out around November. There have been some cases where it's been a little bit late and it's come out in early December, but for the most part, the final rule comes out in November. And it says basically what's in the final rule is as the name suggests, the final rule, the final form, final version of what these proposals are going to look like and what's going to be implemented. Plus, they also do respond to the comments that they received during the comment period. And then the policies go into effect generally on January 1st, unless there's a date attached to it. That's a future date. So sometimes there may be a date saying oh, it won't go into effect until, mid-year, like June of the following year, 2025, or some other future date. But for the most part, most of these proposals go into effect the following year, the first of the following year. Now, what does CMS do with this particular physician fee schedule for 2025 in telehealth? Well, part of the sort of issue or part of the factor that kind of really impacted the type of proposals that CMS made in this particular year for the physician fee schedule was really impacted by the looming deadline for the federal waivers on telehealth policy in the Medicare program. Right now, as probably many of you who are watching this video know, the deadline is set for December 31st, 2024. So by the end of this year, those temporary waivers on telehealth in the Medicare program, such as allowing it to take place anywhere without having to meet a geographic requirement, and they can take place in the home, allowing all eligible Medicare providers to be able to like provide the services. Those things will go away by the end of the year unless some further action is taken. And a lot of those actions that need to be taken by Congress. So CMS was very limited in what they were able to do. But they tried their best within their scope of their powers to try to create an environment that allowed them some flexibility to address whatever might happen, whether, the temporary deadline is, changed to a future deadline or whether it comes to pass. They try to create this sort of scenario or sort of environment with their proposals in order to give them enough flexibility to act, because they did recognize and they were very aware that should these temporary policies actually do end at the end of this year, starting January 1st, we revert back to permanent telehealth policy. CMS was very aware that that's going to impact a lot of people and potentially, cut off services to them, cut off access to services. So they tried their best within their powers to create this environment to try to minimize those impacts of like cutting off these services abruptly. And we're going to get into like exactly what they proposed. Now, I put this up here because a lot of what they propose impacts these particular areas here. So a lot of telehealth reimbursement policies are usually built around these four elements: the location, services, modality, and provider. So the location of where the patient is during the time of the service that's provided, the modality that's used to provide that service, and the provider who's providing that services. And if you look at any sort of reimbursement policy, whether you're talking about Medicare or Medicaid or even like commercial payers, there's usually, something in that policy impacting one or more of these elements. So for Medicare telehealth reimbursement and coverage policy, this is true as well too. But sort of like where the authority on how to change that policy varies. It could be embedded in federal law and it's statutory, or it could be an administrative issue that CMS has oversight on. And I've divided this up for you to be able to see that some of these issues or some of these areas and policies CMS may not have control over, or they may have limited control because the power to change them is embedded in statute, and that would require Congress to act. But we'll also see as we go through the presentation that the proposals really align up to like, these particular areas in the type of proposals and what they would impact. So the first thing we're going to look at is services. And as you can see up there, I have it's both statutory and administration. Now, this is a little bit unusual in that, yes, it's embedded in federal law and you would need Congress to change it presumably. But if you look at the federal statute where this is located, there's like a little bit of it out there for CMS. So in federal statute saying like what services are covered if telehealth is used underneath the Medicare program, they list a couple of things such as, consultation services, and then they add this other thing or whatever other services that the HHS secretary decides. So that little out gives a lot of administrative power to CMS to decide what services will be covered if telehealth is used. So what did they suggest? So last year, within the physician fee schedule, CMS suggested actually a new process and how they were going to like approve new services to be added to the permanent telehealth list or the telehealth eligible services list. And it was sort of a combination of like sort of this previous process they used. But basically, what happens is that the public can suggest what services to add onto that list. And sometimes CMS also have their own ideas of what should be added. And then they'll like go through this 5-step process to see like, oh, would it qualify to get on the list? And we have on the CCHP website a link to like last year's proposal and what that 5-step process is. But essentially, they kind of look to see like, does it fit in? Can the service be provided via telehealth? Services are either approved to be a permanent or a provisional status. So permanent means it goes on the permanent list. It stays there no matter what, or until a future date they decide to remove it. Provisional status means it's got a time limit on how long it's going to be there, and it can be removed at, anytime. So what they proposed is a lot of codes to be put onto the list as in a provisional status, and we listed them there. But they did propose 2 codes to be on a permanent status, and that's G0011 and G0013, and they're related to counseling around HIV. So this is like what they're doing specifically with that telehealth eligible services list. Now, what they are also doing around like services related to technology providing a service are a couple of other proposals. So for those who may not be familiar, the American Medical Association are the ones who come up with those CPT codes and their definitions. And last year, I believe it was last year, they came up with a set of telehealth specific services codes and have basically said like these should really replace like the usual office codes that people are using now, but they're using a modifier signifying that they've done it via telehealth. These are now codes that like really are very similar to them. And there were about 17 of those codes, and CMS did take a look at them and said, like, at this time, we're not going to adopt those codes because they're already sort of existing codes, and there's some things in statute that we're not quite sure would really allow us to adopt these codes. However, they noted that one code that AMA suggested, 9F091, was very similar to G2012. And for those who are involved in billing or very familiar or have some familiarity with telehealth technology delivered services, know that G2012 is one of the communications technology based codes, and that's the virtual check-ins. So this new code would now replace this code underneath these proposals. They also noted that 99441 to 99443 codes were deleted by the AMA CBT panel. And CMS said, like, when the deadline hits at December 31st, 2021, we are going to put those codes into a bundle status. So they're not going to be listed as individual codes on the services list. And then a couple other things that they did were additional new codes to allow clinical psychologists, social workers, marriage and family therapists, and mental health counselors to use interprofessional consultation codes. Again, those interprofessional consultation codes are communications technology-based services codes, CTBS codes, similar to like the G2012 code. And then additional new G codes for behavioral health. So this is like the whole thing in the 2025 physician fee schedule proposals related to services that CMS has proposed. Now we're going to move on to modality. And modality is really, for the most part, administration based. Again, if you look at what's in federal law, the statute only says that a telecommunication system needs to be used to deliver the services. And they really left it up to CMS to define what that is. And over the years, CMS has like refined what exactly it means. So CMS is proposing to change the definition of interactive telecommunication system. Now I want to pause there because, for one thing, in federal law, it only says telecommunication system. A while back, this actually predates CCHP's time, I believe. CMS added the word interactive. So that's not, that full term is not based in federal statute, just telecommunication system is. Interactive was added during the regulatory process by CMS. So that kind of shows you sort of like really the control CMS has over like defining what this particular term means, because it's not defined in federal law, it's defined through the regulatory process. And over the years, they've like, tweaked this definition a bit, and they're thinking of like tweaking it again. They have a proposals to also include audio only for other telehealth services when the beneficiary is in their home, and when other certain elements in the situation appear, such as the patient is not capable of using video or doesn't want to use video. So this would change the definition of interactive telecommunication system to allow audio only to be used for other services besides mental and behavioral health. Now, this is big, but it is also limited, and I'll get into that later into the slide, but this is a significant proposal. I'll see, like, while this is like an expansion in some ways, it may not be as big as some folks think. But this is significant in changing a term to like add audio only in as like a modality that providers can use to provide services. And like I said, towards the end, I'll explain why this could be sounds good, but it also can be like it's actually kind of limited as well too. The next thing is the provider. So the provider, and you'll see it's statutory right there. So CMS is really, really limited in what they're doing. They cannot change the provider list. That is something that is very specific in federal law. So CMS doesn't really have the power to say, like, we're going to add federally qualified health centers to the eligible telehealth providers list. No, they can't do that. That is something Congress would need to add. So what did they do then? Well, again, going back to like what I was talking about with audio only and changing the definition for interactive telecommunication system, CMS can make some administrative changes related to FQHCs and RHCs as well too. So what they're proposing is, at least on a temporary basis, is to continue to allow FQHCs and RHCs to use telecommunication technology for their non-behavioral health visits. And this is done again to try to mitigate the potential impact should that December 31st, 2024 deadline come to pass and nothing has changed. There are a lot of patients, Medicare enrollees, who are receiving their services via telehealth from FQHCs and RHCs. And if this sort of like route is not there, they can see that abrupt cutoff starting January 1st of 2025. They are also suggesting delaying the in-person visit required for mental health services furnished in the home for via telecommunications for FQHCs and RHCs. So some of you may be aware that a couple of years ago, what was put into permanent telehealth policy by Congress, it was in a piece of legislation, it was the Consolidated Appropriation Act of 2021. They said that mental and behavioral health services can take place in the home via telehealth, and Medicare will cover that. But they had a caveat and said, like, but a prior in-person visit between the telehealth provider and the patient needs to happen. And CMS had mirrored this policy when they redefined what a mental health visit meant for FQHCs and RHCs to allow them to use like live video and audio only. They mirrored that required in-person visit for the FQHCs and RHCs as well too. Now, this would delay that in-person requirement only for FQHCs and RHCs. You're going to probably, some people are wondering, well, did they make the same delay for all other practitioners as well too? And no, we did not see that in the proposals. And the reason goes back to because that was embedded in federal statute. As I mentioned just a moment ago, it was put in there by Congress by the Consolidated Appropriation Act of 2021. So it's in federal law. CMS can't change that. But because they made this regulatory change on the definition for what a mental health visit meant for FQHCs and RHCs, they were able to do that through regulation, through the physician fee schedule for FQHCs and RHCs. No, it can get a little confusing, but it is really important to understand where was this policy established? Was it policy established by federal law, or did they do it through regulation? And then that's where you can see, like, how much leeway CMS has to kind of like, change or make a suggestion in like, how telehealth can be used, or how, if it can be extended to be used beyond what we know right now is going to be the deadline of December 31st, 2024, unless some further action is taken. Location. So this is also statutory as well. It is embedded in federal law. A lot of you are probably familiar. It says like it needs to take place in a specific rural type of area. It needs to take place in like essentially a clinical setting. Home is allowed for a certain amount of services, a very narrow band of services, but location is statutory, and there is not a whole lot the CMS can do about it. And for the most part, they didn't really have a proposal related to location as well. So I don't have a slide on that. We're going to jump to like the next topic. Just wanted to point that out. I did move essentially from like where CMS had the most power to like basically they couldn't really do much. And that was like around the location. So impacts proposals and what they might be. Now, I talked about earlier the audio only, like changing that and allowing that to be like a modality for like all services that telehealth provider can use, as not just for mental and behavioral health when the beneficiary is home. And I said, like, it sounds great, but it's really like limited in some ways because of like the other permanent policies that impact the use of telehealth in the Medicare program. So yes, the modality may have been opened up, but you still have all the other elements that impact the use of telehealth. And that is the services that are allowed, the type of provider who provides the services, and the location as well too. So all of those permanent policies, if they do not change, will really blunt the effect of allowing audio only to be used for something other than mental behavioral health services. You're still going to have like, well, if we revert back to permanent policy without any changes, you're going to have like limited types of providers who can provide that services. And also more importantly, there's only a certain amount of services that could take place in the home. So yes, it sounds great and everything. And yes, it is an expansion, but these other policies and the way they all work together really kind of blunts the impact of like what we're going to see of like this policy potentially having. So I just wanted to put that out there for folks to understand, like, yes, it sounds good. Yes, you probably want to provide comments and everything, but also understand if permanent telehealth policy Medicare does not change, they are going to be mitigating factors that really kind of like um reduce or limit sort of like the expansion or the impact that that policy could have. Now, other telehealth proposals that are out there, and I'm just going to run through these really quickly. The slide is available on our website. If these slides are available on our website if you want to download them. But basically, it's aligning like things that have happened. Opioid treatment program, SAMHSA had made some changes earlier in the year, and CMS is just sort of aligning with what SAMHSA did with like opioid treatment programs and their use of telehealth. Frequency limitation. So there were frequency limitation on certain services taking place in certain types of locations, such as nursing facilities and inpatient visits and critical care consults. That waiver was extended to the end of this year as well, lining up with a lot of other telehealth temporary policies deadline. But CMS, again, something that they can have control over. They are saying we are going to extend the frequency limitations for an additional year, so till the end of 2025. Other telehealth proposals around direct supervision. Again, this is essentially one they are suggesting make permanent. That is the immediate availability one, but a lot of these were also extended an additional year until the end of 2025. And again, the reason CMS is able to do that is because these things are based upon sort of like their existence based upon like regulations. So CMS has the power to do that. They don't have to wait for Congress to act to allow them to make these moves and these suggestions. And then other telehealth proposals, the originating site fee will be now $31.04. And there was also like a lot of folks who are concerned about this, and that was you providers having to put down their home address when they were submitting claims to CMS. CMS like allowed providers to use like their practice location address, even if they were in the home during the time of telehealth interaction. That was, again, something that was extended to the end of this year. It's now extended until the end of 2025. And then a creation newly defined set for advanced primary care management for FQHCs and RHCs. This is pretty involved, so I'm just not going to go into it. I put like the page number there if anybody's interested on it. They incorporate coding elements that currently exist in how they do it for communications technology-based services for these new APCM sets of services. So if you want to get into that, that is the page number that's located. And the page number I'm giving is for the unpublished version of the physician fee schedule, not the one which I think in about a week or two that will formally appear in the Federal Register. I just personally think it's easier to navigate the unpublished version. So that's the page number that you'll find that particular, the APCM discussion on in the unpublished version. Request for comments. You are allowed to give comments on anything that is in the physician fee schedule, but there were specific requests from CMS on specific things that they really wanted comments back upon. And one of them was on them redefining what a visit meant for FQHCs to include live video. Now, I mentioned earlier that CMS had made a change to what a mental health visit meant, and they included audio only and live video. So that's for a mental health visit. Now CMS is saying like, well, maybe should we do it also include live video for a visit and the definition of visit for FQHCs and RHCs. This is just a proposal, so it's not within the proposal, or this is just a call for comments. It's not an actual proposal. They want people's thoughts on this idea. They're not proposing it yet. But let's just say this was a proposal. What exactly would it do and what would the impact be? It'd be very similar to what the mental health visit change did for FQHCs and RHCs. And that essentially allows them to use telehealth technology to provide services. So if they changed the visit to allow them to use live video, FQHCs and RHCs would be able to use live video to provide those services to their patients. That does not make them a telehealth provider. It changed the definition for what a visit meant. It did not put them onto the eligible provider list. It just changed what a visit meant for these entities, these organizations, and it means that they can use live video. What that also means is because they're not regarded as providing services via telehealth, because they're just providing a regular old visit underneath like what that means for them, those telehealth limitations in law don't apply to them then. So, the geographic requirement, and so the types of providers, those things would not apply because they're not providing a telehealth service. They're just providing a visit. Again, if this was something that they implemented. Now, CMS is not saying they're implementing this for 2025. They just want people's comments regarding it. So if you are really interested in that particular idea and you have some thoughts on it, you really need to get that into CMS. And then the other thing that was interesting where they requested comments, and kind of very similar to the first point, is that CMS said they weren't going to adopt those AMA codes except for that one exception I pointed out. But they do want to ask, like, what are your thoughts on it really fitting into those statutory restrictions that were in federal law on telehealth in the Medicare program? Because again, these codes, they're saying like, well, these aren't your typical service codes. These are like new codes that are being created. Would they fall under that statutory definition there for services, for telehealth services? If they did not, then similar to like the FQHCs and RHCs on them having their definition for visit redefined, if they're not regarded as telehealth underneath the federal statute parameters, then those restrictions may not apply as well too, or those requirements such as being in a certain geographic area. So again, this is not a proposal that CMS is making now. They just were asking folks for their thoughts and what do they think about that. So that is, if you're interested in either one of those or in both of them, I really encourage you to like provide your comments to CMS. They are, I think, really interested in hearing what people think about these two ideas. And who knows, we may see them as like future policies, not for 2025, but maybe for 2026 or 2027. So deadline for comments, it is September 9th at 5 p.m. They did not put a time zone. I would assume it's probably Eastern time. I would just also say make that assumption it's Eastern time, just so you know that even if it's Pacific time or something, or a later time zone or a different time zone or something, you got it in a couple of hours early. So September 9th, or even better, maybe get it in before September 9th. There was a panel that I moderated with CMS just a few days ago. They did suggest and say, like, the sooner you get your comments in, the more time we have to like go over them. So I would highly encourage you, if you are interested in providing feedback to CMS, to get your comments in as soon as possible, just to allow CMS time to like really thoughtfully look at and evaluate what comments you sent in. So you can find a fact sheet on the CCHP website where we go into detail and break down these proposals and everything. We will definitely keep folks updated on this process. Again, the deadline for comments is September 9th. The final rule usually published around November. So look out for that towards the end of the year. And also keep an eye on what Congress is doing, because they have the ability to kind of like disrupt everything that CMS has set up. But I think CMS has like kind of positioned themselves well enough to respond to like anything that might come down from Congress. So anyway, thank you very much for listening to this video. I hope you found it helpful, and please stay tuned for future videos from CCHP on telehealth policy. Have a great day.